All right. For those of you I haven't talked to before, my name is Samaya. I am an antimicrobial stewardship pharmacist with MDstewardship. And today I'm going to be presenting with Ashley.
Hi guys, I'm Ashley Mauser. I work in Kentucky at Hardin Memorial, and I'm going to be co-presenting today. Nice to see everyone on the call.
All right, so today we want to talk about antimicrobial stewardship, basically daily pharmacist interventions. So make sure you guys can see my slides. All right, so we just want to go over some of the things we do for daily antimicrobial stewardship review and some review from the IDSA guidelines. So some of the objectives we want to go over, we want to start by figuring out how to identify the patients that we want to review for discussion for antimicrobial stewardship. And then we want to talk about the steps we take to review these patients and then how to review this patient and successfully provide a recommendation. And then finally, we want to talk about some of the resources that we have to help us with our stewardship recommendations. Sorry. So what are some of the antimicrobial stewardship strategies? So these are outlined in the IDSA guidelines. I won't go through all of them, but we're going to go over just a few, the ones we see and use most often. So the first one being the prospective audit. This is the one that you're probably going to be using most often. So how to identify our antimicrobial stewardship patients to review, if we have computerized decision software to help us in the review, and then even in clarifications prior to verification of antimicrobial orders. Another big strategy is providing education related to antimicrobial stewardship and then starting some facility-specific clinical practice guidelines and algorithms. So we'll go through these all in depth. So we'll start with prospective audit. Again, probably the most common. So here are some of the general intervention types that we use for this prospective audit. So one of the main things that come to me when I'm reviewing patients is probably alternate therapy. So when looking at the patient, is this the best therapy per the guidelines? Can I use something that's a little bit more narrow or even broad in some cases? And then if I have cultures, is there a bug-drug mismatch? Like, for example, do I have ESBL growing that I need to switch to alternate therapy? And then also, if I have cultures, can I streamline or de-escalate based on the cultures that I have? Some other things we have that we'll go over later, like dose change or reviewing like duplicate therapy. So clinical support software, excuse me, if you have it, is very helpful. So I'm most familiar with Sentry 7 or Theradoc. And so basically these will give you alerts if you have like duplicate beta-lactams, if you have any positive cultures. For me, that includes any positive influenza. Sometimes it'll alert me for new procalcitonin orders. But you have to keep in mind that these are just support softwares. It's not all encompassing. It doesn't do the full antimicrobial stewardship review. So for me, it's just like a starting point. So after I've reviewed my alerts and looked at those patients, then I've learned and been taught to start with my ICU patients and just like manually review from there on. Like for me, some days I have over 100 patients to review, so obviously it's not going to be possible to do all of them, but how I do it is basically start in the ICU. Those are going to be your sickest patients, obviously. A lot of the time they're going to have like the broadest spectrum antibiotics. They're going to have the most combination of antibiotics. They're also going to be at the highest risk for like C. diff infection, so a lot of opportunity for intervention in those patients. And then after reviewing that, I basically work my way up the units as I can. Also, the microbiology lab is a great tool. I find myself calling them almost every day, and thankfully they haven't started hanging up on me yet, but they help me review cultures. So if something is in the EHR and it's not really clear, if I can't tell if both sets are positive, for example, they'll go over that with me, or looking at a gram stain, or even like running additional susceptibility when needed for a patient. But if you don't have the clinical support software, and sometimes it's overwhelming to find a place to start, and if you can't build these rules like in your EHR, then sometimes it's helpful to prioritize patients. And these are just some things that could be helpful. So for example, starting with patients that have positive cultures. Now, this doesn't have to be just blood cultures. So if, for example, in your pharmacy, you get a faxed microbiology report of positive cultures, those could be the patients that you could start your review on, just reviewing them, reviewing if there's any bug-drug interactions, any inappropriate therapy there. And then also when reviewing like pharmacokinetics, like vancomycin dosing, you could see if there's opportunity to switch from vancomycin if you actually have MSSA as opposed to MRSA. And then another way you could do this is doing a drug search report. So for example, if you just want to focus on broad spectrum antibiotics, so, do a search of like all the meropenems, or I'm sorry, the carbapenems, like for example, meropenem, or do a search by your high cost, so like aztreonam or daptomycin, and then just review those patients for accuracy, basically, and then if there's stewardship potential for intervention there. And then also if you have like any institution-specific targets, so for example, if you find that in your institution you are using fluoroquinolones too frequently and maybe not appropriately, those could be patients that you could target daily on your review to make sure these fluoroquinolones are appropriate for the patient and the best choice that we have.
Okay, I'm going to kind of shift gears a little bit, and now that we've talked about like how you identify patients to review, we're going to talk through just really how to review a patient. And we don't mean for this to seem overly simplified, but I think sometimes when you go to review a patient, they are complicated. Sometimes you'll have patients that maybe you're jumping into their review after they've been in the hospital for several days, and so I'll just kind of walk through, I guess, a potential process that might be helpful for reviewing antimicrobial therapy. So I usually start with the indication for the antibiotic. So at our facility, we can see when the physician ordered a particular antibiotic, they have to select from a drop-down box as to the indication. So it would give us kind of a broad example would be like chest infection, skin and soft tissue, bone and joint. So I usually like to start with when the physician prescribed it, what was their intention to treat? To see if that is still the same infectious process that's going on a few days later or when I'm reviewing it. The next thing is I looked at the additional imaging. So as we know, a lot of times infectious process can mirror other differential diagnoses. So for example, heart failure could look like pneumonia on the chest x-ray initially. So I like to dive into reviewing like the chest x-rays, CT scans if they're available, just looking at the different imaging to see if it will give us more perspective on what's going on with the patient. Next, I think it's good to look at the microbiology results, and also not just the results, but what is still maybe pending or was ordered but hasn't been collected. So you may be able to see that sputum cultures were ordered, but they haven't been collected, and so we may be able to just prompt having the nurse or the respiratory therapist collect those. Also, I like to look back like a little bit further. The way our chart is set up is that it doesn't show historical visits. Like I have to kind of open up the chart and take a deeper dive if I want to see like the entire patient history, but I like to do that because then it can tell you what organisms they've grown in the past, if they have risk factors for MRSA, if they've grown Pseudomonas in the past, or maybe if they have a history of like ESBL. So I think it's always good to kind of look at the bigger picture if you have that available in your medical record. Then I like to go into reviewing labs. So looking for things like what's the white count, what's the trend for the white count, procalcitonin, if you have that and you're able to use that and to assess like a trend for improvement. Also, have they been febrile? Because sometimes that will cause a physician to make a reaction to broaden therapy if they've had a new fever. So I always like to know those things. And then I also think it's really important to just think about clinical status of the patient. So are they clinically improving, getting better based on the progress notes, or are they clinically unstable and potentially getting worse? So if a patient was in the ICU, we would be looking at things like, are they on vasopressors? Are they getting, if they're improving, maybe they're getting extubated and now they're getting ready to go to the floor. What have their blood pressures been? So really trying to pair the antibiotic and the infectious process with the patient's status. So let's see. Maybe see. Do you all see patient? I don't know. I think I'm a little behind on. There we go. Okay. Sorry, we're trying to screen share here. Okay, so if you're a visual person, then this is just a flow diagram that kind of summarizes what we just talked about. I just kind of put it in a different view in case that kind of helps to walk through that. So next we're going to talk about. Sorry, I think mine's a little delayed. So Maya, can you? Yeah. Can you go to the duplicate coverage? There we go. Sorry, mine's kind of delayed. Okay, so just to kind of touch on a few things that are real easy to pick up on and to potentially make stewardship interventions for would be common duplications in therapy, and these happen a lot more often than you think. But there's a lot of times just a misunderstanding with physicians, and they will may potentially prescribe duplicate anaerobe coverage. For example, pairing metronidazole with piperacillin and tazobactam. So a good way to approach this would be to educate the provider and let them know that pip/tazo has excellent anaerobe coverage and that we potentially do not need the metronidazole. Also, we see this a lot. Our order entry pharmacists that are doing verification are really good at catching things on the front end. So, for example, sometimes the physician will they are intending to broaden therapy and go from, for example, ceftriaxone to pip/tazo, but they forget to discontinue the other antibiotic, and then that could create duplicates. And so that's something that just to even educate on from the front end, so that those don't go on for a day or two before someone catches it on the back end. We go to the next one. Okay, so now we're going to talk about, I think this is like the one of the stewardship initiatives that is it's super easy and it's really effective. So we oftentimes think about like changing antibiotics, optimizing the most appropriate antibiotic, but sometimes it can be just as easy as going from an IV therapy to an oral therapy. And this can be incorporated. I'm sure maybe some of your facilities have a protocol-driven IV to PO switch. I would encourage you to just kind of keep adding antibiotics to that and expanding that. If you utilize PharmD students, this is a great activity for them because if it's protocol driven, they could review the patients, assess if they have good oral intake, and then initiate the interchange to the equivalent oral dose. Our nurses are really starting to take an active role in this in helping to identify patients. So if they know, it's a lot easier for them to go in and administer a pill versus to have to prime an IV line and start the infusion and come back and flush the line. So they're trying to also be engaged in this process. So let your nursing folks know like which antibiotics are eligible for that interchange, and they can help to prompt you. Okay, so now we're just going to talk about how to successfully deliver recommendations. And I don't want this to seem too elementary either, but I've kind of learned sometimes the hard way, like how to have success in giving recommendations, and have tried to kind of tailor things throughout my career and to have more effective recommendations. So I'm not sure like how most folks go about making their recommendation, but for me, it could happen a multitude of different ways. A lot of times I'm going to be in person and try to introduce myself. If it's during rounds, that's a great opportunity when you're stopping at the patient bedside. If you have multidisciplinary rounds, hopefully if your doctor already knows you, you might not have to introduce yourself. But if you're dealing with a lot of different providers, they may not be familiar with the stewardship program and the pharmacist role. So I think that rounds is an ideal time, and a lot of times as pharmacists are gaining comfort with making recommendations, simply just stating what antibiotics the patient is on and the day of therapy, and then reviewing any cultures can almost automatically trigger a de-escalation and a timeout with that physician. You don't even really have to feel like you have to have exactly the plan in mind, but just talk about it, bring it up. And then that would give the physician time to say what's going on, or, oh yes, I think we could potentially narrow this. So that's a good place to start, especially if you're just kind of getting more comfortable with antibiotics and with stewardship. Also, if you talk about timing, it's important to think about, like, if the physician has seen the patient already. Sometimes, like when I'm talking to physicians, I can tell that if I approach them really early in the day and maybe they have a lot on their plate, or they're trying to cover their most critical patients, that they would be appreciative if they had a chance later in the afternoon to just assess the patient and to see how things are going, and to make that assessment later. So you could use a lead-in of, when you review the patient today, could you consider assessing the need for vancomycin and consider this? And then you could kind of follow back up after the fact. So this is just kind of an example. We use a lot of secure texting at our facility. So a lot of times I will just pull up the provider that's caring for the patient for that day, and then I'll introduce myself. So it may go something like, I was reviewing this patient and I noticed a lot of times it's reviewing them related to the dosing. So that's kind of one way to intro. Like if you're reviewing vanc, it's because you were consulted to manage it. So that kind of breaks the ice as to, like, why were you looking at Miss Smith? Because sometimes I've gotten that, well, they kind of feel like we're like, I guess maybe, why are you looking at my patients? I don't know if anybody else has gotten that before, but I usually just introduce it as the stewardship team was reviewing, or this hit my list because, and kind of give them an intro as to what your involvement is in that patient care. So in this place, the patient was growing MSSA, so I would say, could we consider changing from Zosyn to cefazolin? One thing I've learned is that you always want to look at allergies and things on the front end, because sometimes, you'll want to make a recommendation based on the drug of choice, but then incidentally you see that they've have an allergy to that. Also, I think it's important to know the rationale behind the recommendation and to know, like, why something is preferred. So it may be that there are better outcomes with cefazolin as compared to vancomycin for particular disease. Also, I think you have to think about safety and efficacy, and kind of bring those things into the conversation, and then always tie it back to the guidelines, because that gives, I guess, it substantiates your recommendation. So I will routinely kind of say, according to the IDSA guidelines, this would be, the recommendation. Also, we just kind of mentioned, like, the way that you can word things is important. So you probably want to avoid saying, like, we think you should, or statements like that. If you can kind of get with the physician and try to think on their level. So if they are wanting to continue an antibiotic, then just try to dig in as to why they feel that way. And I think if you can approach it as being on the same team, then the recommendations usually have a lot more success. And then when they also know that you're going to call when you think something needs to be broadened, then they don't always feel like we're always, typically we are always trying to narrow, but we always want to think about optimization, and sometimes it's just to broaden a coverage when you feel like that's necessary too.
So I know we've gone over several things that we can do, several different recommendation types under the prospective review. So just to go over them really quick or hit on the ones that we didn't talk about in depth. So dosing is obviously really important, and a simple intervention. So renal dosing, or even with pharmacokinetics, like with your vancomycin, wanting to make sure you have like a higher trough goal, like closer to 20 for a suspected meningitis patient, for example. And then also like alternative dosing, so extended infusion beta-lactams, most commonly Zosyn, so that is a good intervention. Also, like we talked about, looking at all kinds of positive cultures, making sure that the patient is on the correct antimicrobials. And then if you are reviewing your broad spectrums, looking at potential for de-escalation, but also sometimes needing to escalate. Like we mentioned before, maybe patients have ESBL or more resistant organisms, or even like needing additional antifungal coverage. So it's not always de-escalating when reviewing the patient. And then also, like Ashley mentioned, redundant therapy, so duplicate beta-lactams or duplicate anaerobic coverage are things to look at. We want to move on to the next stewardship intervention, so provider education and providing antimicrobial stewardship related education for providers as well as pharmacy staff. So there is always new updates and guidelines. This season we have the new updates in the influenza guidelines, so that's something you want to make sure like all the antimicrobial stewardship staff know about, or the pharmacy staff, as well as all the prescribers. And then if you notice specific prescribing trends in the hospital, like for example, if there are certain providers that like to use carbapenems, let's say in pre-op, then maybe addressing that and coming up with like a new hospital protocol, something that lines up with the guidelines for surgical prophylaxis, just for example, and using that also as like a teaching moment. And then if you have new hospital policy, if it's something you came up with in P&T or Antimicrobial Stewardship Committee, just making sure that everybody is informed on that, teaching them why. For example, if you have something in regards to who gets a urine culture, if they have a Foley, for example, then making sure that everybody is on board and everybody understands the guidelines behind why this policy came in. And then finally, and having an antibiogram and making sure that everybody can access it and that everybody knows how to use it. So this is really helpful for especially like recommending empiric therapy. And then Ashley has her antibiogram.
Yeah, so this is just a screenshot of our antibiogram. It's a couple years old. I'm getting ready, or I guess it's from 2017. I'm getting ready to do an updated one. But I think the antibiogram is an important tool, and if you can incorporate it into the electronic record, like we have it as like a shortcut link on our intranet, and then also like in our EMR, so it's really quickly accessible for physicians and for pharmacists. And also it's really nice when you're rolling out the updated antibiogram to try to incorporate stewardship things with that. So you could hit some highlights of different guidelines that have maybe been updated recently, try to tie that in, and that seems to have been effective for us. And we like to list like our restricted antimicrobials, which you saw those in red.
Jumping ahead.
Okay, yeah, okay, you can go to the next one. Okay, and so I just thought this would be helpful. I'm not sure, everybody kind of comes into stewardship maybe at a different level. When I first took on a stewardship role at the facility I'm at now, I did not have, I had some general antibiotic knowledge, but didn't have a lot of background specific to stewardship. And so it's good to kind of build your toolkit, I guess, as you're growing your clinical skill set. So one thing I would recommend is to consider like a certification course if you are a leader for the stewardship program at your facility. It's the Society of Infectious Disease Pharmacists, SIDP, has a program that's like 40 hours of CE and you get a certificate. I believe there's one from MAD-ID as well. But those are great things to kind of just really build a great primer for stewardship leaders. Also, just having things like the Sanford Guide, don't be afraid to ask your organization for support with resources. So maybe they could get a subscription to the Sanford Guide or get pocket guides for a pharmacist. Also, John Hopkins Guide is a great reference. And then we're fortunate to still get to use UpToDate, which links into LexiComp. So the dosing correlates with, if you are looking at dosing in UpToDate, it will link you to LexiComp. And I use that quite often. And then also just like the IDSA guidelines. So those are pretty accessible on the internet, but you could also save those in like a file as a quick reference for the ones that you would use most often.
Yeah, and I would have to say that I probably use almost all of these every day. Just as I'm reviewing my patient, Sanford Guide, probably like 50 times a day. If there's like a weird bug, it has dosing, it has some resistance trends. UpToDate obviously is really helpful. And then the IDSA guidelines. So I feel like I pretty much use these on the daily. So we just wanted to end with going over a patient case together, just basically like a thought process that I go through when I'm reviewing a patient case. So we're going to start with, we have a 67-year-old male. He presents to the hospital with a chief complaint of weakness and altered mental status. This patient has a history of BPH and has urinary retention and has been straight capped. In the ER, he has some leukocytosis. His white count is 21. He has an elevated procalcitonin at 30. He also has some bandemia, and his serum creatinine has jumped from his baseline. Also, we have his vitals and that he has a temp of 101.8 in the ED. So we look at his allergies. He basically really only has a sulfa allergy, but he ends up getting started on meropenem, levofloxacin, and vancomycin. So the patient gets admitted to the medicine floor. He has blood cultures pending, and he has urine cultures pending as well since his UA was positive. So let's just say this patient came in over the weekend and you're reviewing the patient Monday morning. So we're on day 3 now. Patient is still on triple therapy. The good thing is his procalcitonin was repeated and it's gone down by about 50%. He's not having any more fevers and he continues to be hemodynamically stable. Also, he got a lot of fluid and his serum creatinine has improved from where he was when he came in. But we do have blood cultures that are positive for gram-negative rods, no ESBL identified there. And you also have urine cultures that have gram-negative rods, also no ESBL identified. Before you want to make a recommendation, you also take a look at his EKG. The patient is in normal sinus and his QTC is about 460. So, like I said, we're on day 3. We didn't notice that any MRSA was isolated. Patient did have an AKI, so maybe we could de-escalate the vancomycin. His last procalcitonin was yesterday. It had trended down significantly, but if we wanted to, we could recommend another one just to continue to trend and make sure that it's going in that direction. Now lab calls you with final culture results. So that gram-negative rod was a E. coli, and it is the same organism on the patient's urine as well as the blood cultures. Still on meropenem. Since the lab has told us that there is no ESBL, it would be appropriate to de-escalate to ceftriaxone 2 gram. Now we're on day 5. You have all your cultures that E. coli is pan-susceptible. However, the patient's still endorsing some nausea. He's not tolerating oral intake that well at that point, so it would be appropriate to continue IV therapy. However, if the patient did want to discharge and was doing clinically better, it is appropriate to recommend levofloxacin since it is 100% bioavailable. So that is just the way I go through a case. I want to give you guys time to just give any feedback, any questions, if there's something that you do differently that you find works and would like to share with us. So thank you guys. We do have a question here. Ashley, I don't know if you want to answer this in regards to IV to PO.
Oh yes, I see that sometimes you worry about the criteria to keep the patient admitted. I really think that it's good to approach that as I guess I don't take that into consideration as much, because I feel like that when you look at trying to expedite discharge, we actually kind of want the patient to be more ready for discharge, and you don't really want to keep a patient I guess in the hospital if they're able, to progress on. So I do know what you're talking about, and sometimes like the physician may want IV to kind of make them qualify, but we don't typically factor that into like our consideration. We do have it written into the protocol that that the physician could I guess could override that change. So if there were an extenuating circumstance, it might be good to write that into the protocol, that they could basically kind of say, do not interchange to oral, and then that's a little bit of an exception to the rule.
And just in general, with all of these antimicrobial stewardship interventions, they're just recommendations. These are just things we want to share with the providers. Obviously, it is their patient. They know their clinical status. So these are just recommendations you want to make, and you don't say you have to do this when you're making a recommendation. Does anybody have anything they would like to share? What was the name of the certification?
Oh, yeah, I can answer that. So it's SIDP, and it's I was looking up on my wall because I had to look at what it stood for, but it's the Society of Infectious Disease Pharmacists, and it's really nice. It's a online program that's you can go at your own pace, and you get over 40 hours of CE. The other one that I'm less familiar with, but it's called MADD, MADD. ID, I think they have another certificate program, but I think you could look those up. And one of the cool things about the SIDP program is that you actually have to submit a project to get your certificate, and it's kind of a great way to like take everything that you learned through the course and then actually put it to use at your facility. And I was able to get that supported by my institution. So it might be helpful to kind of pursue that if you're able to. And we can get the slide deck. Yeah, absolutely. I think I see that as a question.
We'll share.
And I'm always happy to share anything, that we have here. If anyone has specific questions that they wanted to email me or reach out to me afterwards, we can send out my contact, my contact information. I think it's always good to be collaborative because we're all kind of working on the same initiatives, so we don't have to reinvent the wheel.
Yes, me too. Well, thank you guys for joining us.
Yeah, thank you all.